Good evening, everyone, and welcome to the Paul Torrens Health Forum. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. Before we begin tonight's session, which is the last health forum of the academic year, I want to thank the many donors who make this program possible and acknowledge tonight's sponsor, Global Care Medical Group, IPA. We are deeply grateful for your support. As many of you know, this program is named in honor of Paul Torrens, who is now Professor Emeritus at the Fielding School. For more than 40 years, Professor Torrens has guided, mentored, and advised students at our school, helping to shape distinguished careers in public health. In June, the Partners of Care Foundation will honor Dr. Torrens with a Lifetime Achievement Award. This is only the second time the organization has bestowed this honor, and we congratulate Paul on this well-deserved accolade. This event will also recognize friend of the Fielding School, Paul Viviano, who will receive the Vision and Excellence in Healthcare Leadership Award for all that he has done as president and CEO of Children's Hospital Los Angeles in his career. I know this will be a great occasion. Now, we are in the middle of National Public Health Week. One of the themes we're focusing on is social justice in health, which honors the social justice legacy of beloved Fielding School professor, the late Ruth Romer. In a word, Ruth Romer was an icon in public health. She intentionally pursued a career path that prioritized socially relevant work. With a law degree from Cornell University, where she also met her future husband, Milton, Ruth found her unique niche at the intersection of law and public health. After joining the faculty of UCLA in 1962, as did Milton, she became an activist, taking up such controversial health issues as abortion law reform and the addition of fluoride to public drinking water. She also used her legal skills to fight against discrimination of people with HIV/AIDS. She helped create the framework for the World Health Organization to launch the first international convention on tobacco control. Professor Romer was an active and beloved faculty member at our school for more than 40 years. And we are honored to have Ruth and Milton's beloved daughter, Beth Romer, with us tonight. Beth earned a Master of Public Health, and in her 40-year career at Kaiser Permanente, had a wide range of roles involving hospital and medical group administration, strategic planning, quality improvement, medical education, and equity, diversity, and inclusion. Most recently, she was a key leader of the team that created the new Kaiser Permanente Bernard J. Tyson School of Medicine, where she became assistant dean. Welcome, Beth. It's such a pleasure to have you with us tonight to share more about your mother's inspirational legacy.
Thank you so much, Dr. Brookmeyer, for that lovely introduction. I'm delighted to be here this evening with so many of my parents, colleagues, and friends, and mine too. Many of you knew my mother and were influenced by her views of social justice. I want to tell you a little about her profound influence on me and how she informed my outlook on social justice growing up. My mother was a remarkable woman. She was the matriarch of our family, even though she always appeared to defer to my father, as women of her generation did. In the last 15 years since she died, when there's an important decision to make, mine or one of my grown children, I always ask, what would Ruthie say? What would Ruthie do? Fortunately, I feel I internalized enough of her life lessons for me to say, I think Ruthie would say this. And the kids listened. Her values were crystal clear. She often said that she was fortunate that her vocation and her avocation were perfectly aligned, and that that's what brings joy in life. She lived her life with this consistency of word and deed, professional and personal. Let me give you a couple of examples. As Dr. Brookmeyer said, she worked on fluoridation of the water supply, and that was when I was a child. Fluoride should not be just for those who could afford to take their children or had access to a dentist. She and my father believed it was the only solution to give all children the benefit of preventing dental caries. She lived her beliefs. Before we had fluoridation in the water supply where we lived, she put fluoride drops, then labeled as a poison, into my brother's and my orange juice every morning. Science had shown the benefit and the safety. As a result, we had very little tooth decay. I think she and my father would have been horrified by the lack of science-based public policy that has been abroad in the land in the last year since the pandemic and in the previous government administration. When we moved to Los Angeles in 1962, I was a young teenager. And from time to time, there were young women who would pass through our home. Uncharacteristically, my mother never said a word about them. It was kind of hush-hush. I learned the truth a few years later when Ruthie was working on the landmark California abortion law passed in 1967. That was 6 years before Roe v. Wade. Ruthie was providing a clandestine referral and support service to help women get safe, affordable abortions in Mexico. Ruthie said that when abortion was illegal, rich women could still get safe abortions, albeit expensive, but not poor working class women. She believed abortion needed to be legalized to protect all women and all families from unwanted pregnancy and unsafe abortion, which often led to death. Ruthie lived her beliefs in women's reproductive rights. So you see, she was a great role model in word and deed, personally and professionally. So the lesson was very clear growing up: work to improve the conditions for all, especially the disadvantaged, and live your life aligned with those values. Ruthie cared about populations, as you know, and she also cared about individual people. In addition to her focus on big social questions, she ran a pro bono, solo, social work and employment agency, helping anyone who sought her out with their personal needs. We lovingly called her President of Arrangements Incorporated. If someone needed a job, a contact, a husband, any manner of advice, she would tap into her vast international network of friends and colleagues to find a solution. And if you didn't follow up on the arrangements she made, she would say to you, as she did to me throughout my life, Beth dear, you must do this. And when you succeeded, she would say, Beth dear, that's wonderful, simply wonderful. Perhaps you heard those same words. I'm sure scores of people, many of you who crossed her path, benefited from her wise guidance, her persistent encouragement, and generous praise, especially for those who are studying or working for social justice, as she was. Thank you so much.
Thank you, Beth, for sharing such a personal perspective with us. And now I'd like to continue honoring Ruth Romer's social justice legacy through the next part of the evening's program, the panel presentation and discussions. It's my great pleasure to introduce Dr. Chandra Ford, Professor of Community Health Sciences at the Fielding School and founding director of the school's Center for the Study of Racism, Social Justice, and Health. Dr. Ford's work offers conceptual and methodological tools for studying racism as a public health problem. And for this work, she has received several notable honors and awards. And Dr. Ford continues to lead critical work addressing the intersection of COVID-19 and longstanding health and social inequities. You can learn more about Dr. Ford's work in her bio, which can be found in the chat. I'm so pleased that she is here with us this evening to moderate a timely and important discussion about social justice and health. Dr. Ford.
Thank you, Dean Brookmeyer, for that very generous introduction. And a few housekeeping notes before we begin. We encourage questions from the audience. You can submit questions at any time during the event by clicking on the Q&A button, which is near the bottom of your screen. We will take questions as time permits towards the end of the program. After the session, you're invited to join our formal virtual networking time with your fellow attendees. And we will talk more about that at the conclusion of the program. We here at UCLA conduct our work in Southern California on lands that were originally inhabited by and cared for by the Gabrielino Tongva peoples. And no doubt the displacement of these peoples enabled the enrichment of our land grant institution. I make this acknowledgement to underscore that the inequities we observe today cannot be understood fully while ignoring their root causes. Many in the field of public health are waking up to the urgent need to collectively address the root causes of inequity, which include but are not limited to racism and global white supremacy. Our nation and the world have experienced tremendous upheaval over the last few years. In the US alone, more than 500,000 US residents have died of COVID-19 since January 22, 2020. Put differently, the nation has lost approximately 1.6% of its population over the last year due to COVID. But as disturbing as these numbers are, they mask stark racial and ethnic disparities, many of which are rooted in historical and ongoing injustices. Woven into this public health crisis is a growth in overt manifestations of xenophobia, racism, nationalism, and so on. Now, while the co-occurrence of these patterns may seem coincidental, the health equity champions from whom we will hear tonight have spent their careers carving out paths toward equity and social justice. Equity can be defined as assurance of the conditions for all people to be healthy, and similarly, social justice as, quote, full democratic and equitable participation of people from all social identity groups in a society, and participation that is mutually shaped to meet their needs. This session is organized as a conversation. Each of our distinguished panelists will take a few moments to share something of themselves and the work they do, after which I will pose several questions to the panel and then open up for the Q&A. We will hear first from Dr. Lyons-Jones, who is an internal medicine physician and chief of adult medicine at Watts Healthcare Corporation and president of the Association of Black Women Physicians. Next, we will hear from Dr. Kakari Stone, who will discuss the innovative coalitional work of the Equity and Policy Training Institute. Finally, Dr. Rowe will anchor our conversation by speaking about the critical work she has been leading on the front lines in her role as chief of the Assessment, Policy Development, and Evaluation Unit, and as director of the Chronic Disease and Injury Prevention section of Public Health for Seattle, King County. Dr. Cosette Lyons-Jones is an internal medicine physician, and Chief of Adult Medicine at Watts Healthcare Corporation in Los Angeles. Dr. Lyons-Jones seeks to influence population change beyond the point of care by closing health disparity gaps through community health science initiatives, health management, and health policy, as well as through edutainment platforms. She's also an advocate for improving global health care and has led medical teams to provide care in India, South Africa, and Rwanda, among other countries. Dr. Lyons-Jones is committed to mentoring and helping young women advance their careers in STEM fields and was recently elected president for the Association of Black Women Physicians. In 2018, she completed the Executive Masters of Public Health program in the UCLA Fielding School of Public Health. Welcome, Dr. Lyons-Jones.
Hello, thank you. I'm humbled to be a part of this distinguished panel of workers in the fight for social justice and health equity, and doubly so as an alum of the EMPH program, class of 2018. I'm a part of the Watts Healthcare Corporation family, acting as Chief of Adult Medicine and the Same Day Clinic, which is our urgent care clinic there. Watts is an organization born out of the Watts Uprising of 1965, and it's a sobering reminder of the social equity work that remains to be tackled. Our services include primary care offerings in adult medicine, pediatrics, OB-GYN, or women's health care, same-day appointment, behavioral health, alcohol, substance abuse treatment, and counseling at our historic House of Uhuru. We also have HIV/AIDS services, 5 WIC program locations, health education classes and outreach, including our ADA-recognized diabetes self-management education services and CDC-recognized T2 weight loss program. We have translation services, transportation services, dental care, vision, podiatry, in-house laboratory and medical imaging, mobile dental and mobile mammography services. So we were addressing the SDOH just before it became in vogue or a part of the larger conversation in the public health community. My transition to Watts was a natural progression in my life's journey. The following autobiographies that I'm about to share with you are not meant to be a flowery overcomer's anthem. My life tracks the lasting impacts of health inequity in America and the insidious way that our national narrative of individualism covers a multitude of sins against historically underserved communities. I implore you to listen as I take us all on a tale of 2 doctors. I grew up in Buffalo, New York. I was bused to a college preparatory school called City Honors. And I say it because I'm still part of that school to this day that I went there. I attended City Honors from 5th to 12th grade and did research locally at Canisius College. I returned to my hometown after doing undergrad at Cornell University to actually fulfill my dream of becoming a doctor. I eventually relocated to Southern California to marry my college sweetheart and to complete residency and fellowship training before working as a primary care physician. I was on faculty for UCLA for 4 or 5 years as an assistant clinical professor at a satellite location internal medicine residency program out in Long Beach. I also worked briefly in HIV/AIDS clinic work under a grant-funded position, and then transitioned to a physician-owned medical group, working as an outpatient PCP for 14 years before moving into my current role as Chief of Adult Medicine at Watts. Now that's the first tale. The second story says, I was born to a teenage mother and father. When I was young, my family moved to a predominantly white neighborhood with a growing Black population. I recall walking home from school, grade school, and being chased by a Doberman Pinscher owned by a white family who intentionally let that dog run loose when they saw me. I also remember being chased by a group of Black school children as an older, dark-skinned schoolgirl had her younger brother beat me up because she didn't like the way I looked. My mother was a victim of childhood abuse and neglect and carried these scars throughout her life until her death due to complications of colon cancer at the age of 64. She divorced and tried her best to raise my intellectually disabled younger brother and myself, holding down housekeeping and supermarket jobs for most of her life. Having only an 8th grade education, she was limited in her ability to help me academically, and I was held back in the 1st grade because I couldn't read. Seeking a better life, my mother moved to the West Coast when I was a junior in high school. And seeing education as my ticket out of poverty, I stayed in Buffalo as an emancipated minor. I was keenly aware of my mother's financial situation and secretly took that burden upon myself. I rented a room and received food stamps and a welfare check to cover the bills while struggling to work full-time at night and attending school during the day. I toured colleges alone on a Greyhound bus. I made decisions about where to go by myself. At my large university, I always felt self-conscious of my financial situation. Food stamps, they still sustained me, even in college, and I could not afford nicer clothes or costly activities. In my first year of medical school, I recall taking an exam on the day my stepsister, was murdered. Stress layered on top of my ongoing struggles to make ends meet while studying to become a doctor. I think about when 2 of my Black male study partners being racially profiled in my presence by campus police. Sitting in a study area, we had tables that were covered in books, and my study partners showed proof of ID, of their school ID, as we corroborated that they were, in fact, students in the medical school. Many Black and African-American students were held back from graduating on time from my year of entry, and that included my roommate, who was actually disenrolled from the school. I graduated medical school in 1997 and have since experienced the heartbreak of the premature deaths of 4 of my friends from medical school, all before the age of 50. Due to pregnancy complications, I lost that grant that I mentioned in the first story, that HIV clinic grant-funded position. I continued working part-time in graduate medical education, isolated and ill-equipped to navigate faculty advancement. No one looked like me, and mentoring opportunities were slim. In my next job as a PCP, my predominantly white patient population frequently assumed that I was a nurse when I walked in the room. My first name was often said instead of Dr. Lyons. My one of my patients, middle-aged white female patient, commented about how well I was dressed and how well I spoke, and then she subsequently filed a false complaint accusing me of HIPAA privacy violations. These are just a few of the microaggressions that I endured early in my career. We now know that adverse childhood events and early chronic exposure to stress increases the risk for chronic medical conditions in adulthood. We are learning more about epigenetics and the role of recurrent toxic stress, including macro and microaggressions toward people of color, leading to the development of inflammatory conditions like cardiovascular disease and diabetes. I am able to connect on a deeper level to my patients at Watts because I understand how the burden of generational poverty and ill health can limit choices and shape behaviors. Recently installed as the president of the Association of Black Women Physicians, I am committed to our corporate goals of improving public health and welfare, advancing knowledge for women and the community, and providing philanthropic support for underserved communities and medical students of color. I do not have the luxury of discussing the work of health equity siloed from my existence as a Black woman. And yet I recognize the vulnerable position that telling my story puts me in each time I speak in public forums. Nevertheless, I discuss the work of health equity in the vein of my shero, Dr. Kamara Phyllis Jones, past president of APHA, who dared to call out racism as a public health crisis, educating people through data, stories, and allegories with a call to action. I believe the narrative is important to waking up the masses, particularly those who have limited insight because of the blind spot of privilege. Until we see racism as the driver of health inequity and intentionally act on this awareness as our collective problem, our nation will continue to fall short of its full potential with untapped resources for innovation housed in Black, brown, impoverished, and disenfranchised peoples. Thank you.
Thank you, Dr. Lyons-Jones, for that gift, that personal gift that you shared with us of putting really your own personal story, your own vulnerability out there. We appreciate it. And it serves as a reminder that these disparities we study and talk about are not abstractions. We live them and we bear the scars of them. So thank you very much. And now I'd like to present our second speaker, Dr. Lisa Kakari-Stone, my dear friend and longtime colleague. Dr. Stone is an associate professor at the University of New Mexico, and she has dedicated more than 30 years of public health leadership in advancing health and racial equity for diverse communities. Her collaborative grants portfolio of $26 million spans across the macro level determinants of health, such as health reform, to the community level, to the interpersonal level. Currently, she is the executive director and principal investigator of a National Research Center of Excellence funded by the National Institute of Health, the Transdisciplinary Research, Equity, and Engagement Center, or TREE. A thought leader in health policy and community engagement, she recently launched an Equity in Policy Institute, which is training 14 place-based teams in evidence-informed policy making and the production of equity policy briefs, digital stories, and policy dialogues. Dr. Kakari-Stone has written articles and policy reports and delivered speeches nationwide on racial and health equity and related topics. Welcome, Dr. Kakari-Stone.
Thank you, Dr. Ford. You are indeed a hero and champion to me, and I appreciate being a part. It's an honor to be here tonight to honor Professor Ruth Romer. I thank the UCLA team. Dr. Lyons-Jones, thank you for that story. And I think you've ignited in all of us that we live multiple realities every day, and we only know we can't always know how to walk in each other's shoes. In terms of what that means, but we have to deepen our understanding for each other. I just wanted to highlight a few points regarding equity, and I'm just going to share here quickly. I'm from New Mexico, and I stand on ground that's indigenous land. I also stand on ground that was once Mexico. We were annexed in the late 1600s into the United States. I want to acknowledge that in New Mexico, we have 23 tribes, 16 pueblos, 3 Apache tribes, and the Navajo Nation. The Navajo Nation has one of the largest endowments in the nation after Harvard and other large foundations and institutes. 47% of our population is Latino. We're mostly rural frontier. We are a US-Mexico border state. We have multiple jurisdictions and checkerboard of multiple governments, for example, in the Navajo Nation with different states, tribes, counties in the border region with multiple jurisdictions of city, county, state, and two nations, as well as other tribal governments on the border. As we think about our public health crisis and the introduction that Dr. Ford framed for us tonight, this is a statement from the American Public Health Association. We plan for emergencies. They mentioned that there's 2 emergencies. I argue that there's a triple crisis that we're dealing with. That's the lack of focused interventions to mitigate the unequal impact of COVID-19 on our diverse racial, ethnic, and intersectional communities. The pre-existing conditions of structural inequalities, food insecurities, lack of broadband, geographic isolation, discrimination, racism, and many other inequalities that we've been dealing with, and the unfinished business of civil rights to not have equitable access and health equity. We're also dealing with the triple impact of structural violence, censorship, lack of data transparency, and refusal to adhere to science and federal inaction. These equal genocide of our communities of color. And I put here a recent report by the Urban Indian Institute that talks about when we suppress data and information and don't have accurate data, it's a form of genocide to our first and our most original citizens of the US, it's Native Americans. In New Mexico, similarly to national trends, there are high rates of cases, hospitalizations, and deaths amongst communities of color, but lower vaccination rates. This chart just quickly shows a snapshot that Latinos have 55% of the cases, 42% of hospitalizations, 40% of deaths, but we're looking at only 38%. When we look at American Indians, Alaska Natives, and New Mexico, we're looking at, again, a high proportion of the hospitalization and deaths, but only 10% of vaccinations. We truly need equity in vaccination. It's more than just a number of shots and political optics, which a lot of our state governors and at the federal level have been playing. It's more about getting the shots in the right arms at the right times and building trust with our communities. As we think about the story of Dr. Lyons-Jones, I want to reiterate the critical importance that racism are the intersecting systems of oppression that are not ahistorical, that include historical oppression as well as modern day and current oppression. That plus the moving cogs of intersecting systems of white privilege and power. These all come into play to routinely disadvantage racial, ethnic, and other intersectional communities and routinely advantage white privilege. And I just want to mention, I'll be just focusing tonight on how we achieve equity at the structural and institutional level. How can we tip the scale in honor of the legacy of Dr. Romer? How do we achieve racial justice and health equity? We can't solve our problems using the same solutions and thinking that actually created them. And I want to highlight that in the Poor People's Campaign in the 1960s, as well as other social and racial equity, racial justice movements, including the Civil Rights Movement, the American Indian Movement, AIM, and the Chicano Movement, pervasive poverty and racism had called for a radical redistribution of wealth, land, and rights. It's important that that's what we had in the 60s, and we're still dealing with that today. What do we need to move forward? We need to build trust and reinstate the legacy of human rights. We need data for transparency and visibility and inclusion. We need policy interventions. I wanted to highlight and share with you tonight in New Mexico, in response to the national evaluation of the National Collaboratives for Health Equity, as well as the W.K. Kellogg funded New Mexico Health Equity Network and project, I evaluated these, and there's a lack and there's a huge disconnect between what we know and what we do in terms of policy and racial inequalities. There's a disconnect between policymakers, researchers, and communities themselves. The Equity and Policy Institute fills a huge gap in the nation in that it teaches, I brought together a design team to develop this. It's evidence-based policymaking with an equity lens that really focuses on equity policy, which is actually more about the nature of relationships, about equalizing power and power dynamics in the policymaking process, increasing civic engagement with communities of color and policymakers. Most importantly, I want to highlight that equity in policy is about justice. And it's these 5 types of justice that are critical in terms of thinking about not a value, but an outcome. And we think about distributive justice in the sense of resource allocation, procedural justice in more participation and inclusion of people of color at the political levels, all levels of governance and policymaking, hermeneutical justice. We must think about how people interpret and experience their own lives and not suppress those stories or disregard them. because they're real. Testimonial justice. We need to think about believing people when they share their story, like Dr. Lyons Jones did, and believe them and legitimize and listen. Most important, equity and policy is about restorative justice. We need to think about, as a nation and sovereign nations with other multiple levels of government, how we restore healing and health and resiliency to our communities and to have trauma-informed policies. I want to mention that this institute I launched during COVID. It was supposed to be in person. I was able to recruit a total of 12 teams that are place-based with multiple racial, ethnic, disability, LGBTQ, and rural and frontier different backgrounds. It was a module that lasted 2.5 days, plus over 3 to 4 months of technical assistance and training to the teams that include academic, community, and policy partners. The products that the teams have produced are policy briefs, and they engaged in these half day of policy dialogues would actually promote and foster development of policies that actually look at racial equity. Currently, the 12 teams are in the process of finalizing their products, which will be disseminated. But I wanted to highlight here, even though it looks busy, the diversity and the critical importance from working with Asian Pacific Islander, Asian American communities, to LGBTQ youth in rural areas, to persons with disabilities, to Northern New Mexico rural Hispanic Latinos who are dealing with grandparents raising grandchildren, and also with tribal nations and indigenous communities who are seeking to hermeneutic justice in the sense of health and all policies from a decolonized lens. Thank you.
Thank you so much for those important and valuable remarks, and a reminder that policy matters in the context of public health, and that coalition and participation matter, and that this work actually can be done if that is where we make our investments. Our third speaker is Dr. Marguerite Rowe. Dr. Rowe is the Chief of the Assessment, Policy Development, and Evaluation Unit and Director of the Chronic Disease and Injury Prevention Section of Public Health, Seattle and King County. Dr. Rowe has focused her efforts on working with diverse communities to achieve health equity for our nation's most at-risk populations. She is a former member of the Centers for Disease Control Advisory Committee to the Director, Health Disparities Subcommittee, and a past chair of the Department of Health and Human Services Advisory Committee on Minority Health. As Deputy Director of the Asian and Pacific Islander American Health Forum, she played a leadership role in the development of Health Through Action, a groundbreaking partnership program to close health gaps for Asian Americans, Native Hawaiians, and Pacific Islanders. During her time at Columbia University as an assistant professor, Dr. Rowe also served as senior policy analyst for the W.K. Kellogg Foundation's Community Voices Initiative, a national demonstration project to improve access to care for vulnerable populations. Dr. Rowe obtained her master's and doctorate from the Johns Hopkins University School of Public Health. Welcome, Dr. Rowe.
Thank you, everybody, and I so appreciate being here. And I'm hoping that you can. I'm hoping that you can see my slides at a minimum, right?
Yes, we can see the slides.
Great, thank you. Well, I'll just say again how humbled and honored I am to be with all of you tonight, in particular because it's after 5 p.m. And so to be with a group of committed individuals wanting to address social justice and equity, it's such a pleasure. I wanted to, I'm the daughter of Taiwanese immigrants, and I'm sure most of you are aware, it's been a very difficult time recently for our Asian American, Native Hawaiian, and Pacific Islander communities. And I wanted us to be able to spend a few seconds to reflect on, you know, what it will take for all individuals residing in the United States to be treated equally and fairly. I show you these pictures in part because I get a lot of strength from these pictures. I actually think that these photos show not only the beauty of my community, but really as we look at the individuals, what I see is strength, determination, and hope. I hope that's part of what you see as well. And I also wanted to make sure to just note that this issue about hate crimes is not just an Asian American issue. This is just one wave of incidents that are coming to the forefront due to the historical subjugation and marginalization of Brown and Black people in the US. And I think whether it is the, you know, the small incidents that happen to us as individuals on a daily basis, these are the clarion calls that we need to do something different and something better, and that we really do need to make significant transformations in our systems and policies. So next slide, please. So I wanted to just really quickly appreciate Dr. Kakari Stone for calling out the inequities within, or the disparities in terms of the impact that COVID has had on our communities. And I think what you see in this slide is you see what we would expect to see if all racial and ethnic groups had experienced the same rates of COVID infection as compared to whites. The gray bars are what we would have expected if all groups experienced COVID similarly to whites, and the pink bars shows the excess cases, hospitalizations, and deaths that our communities have experienced here in Seattle, King County. And 2 points that I want to call out to you about this slide. One is the importance of collecting and reporting disaggregated data. It's clear that there have been differential impacts, particularly on our Latinx and our Native Hawaiian Pacific Islander communities. Clearly, there are other populations where we want to have the data that would be helpful to have, whether it's other racial ethnic subgroups, data on LGBTQ populations. We want to be able to understand the impact of COVID on populations living homeless, the formerly incarcerated, domestic sex workers, and others who've been traditionally marginalized and underserved by our existing systems. More importantly, this data should force us to ask why these health disparities exist. What is it about our existing systems and circumstances that lead some groups to fare more poorly than others? Next. So I wanted to share a little bit about what we're doing here in King County. And the first is immediately when the COVID pandemic started, and as you know, it started up here in King County, Washington, we recognized that it was important that we bring our community in. We're working on becoming an anti-racist system. It's hard to believe that a government system wants to do that, but indeed we do. And so we set these principles for equitable vaccine delivery that were informed by our most impacted communities and our equity response team. And so you can see that the principles for equitable vaccine delivery include removing barriers that deter access, creating an inclusive process, and being intentionally anti-racist and accountable to our Black, Indigenous, and people of color communities, as they are the ones who have been impacted the most. In terms of action, what does that mean? It translates into focusing on highest risk and those most impacted, and making sure, for instance, when we do have vaccine available, that we find ways to provide early access or preferred access, working with our communities on what works and what doesn't in terms of the delivery system, doing things like we know that web-based systems are inequitable by design. And so we needed to find ways to make registration easy and to make sure that we make vaccine available to people where they are, not so that they have to come to us. And so we do that by mobile vaccine delivery, by working with our community partners on community pop-ups and those types of things. We provide information to our community partners, and we work on the design of the messages in over 30 different languages. And it's been a challenge, and we know that we're still not meeting and reaching everyone. Next. So here's a list of some of the groups that we have worked on, but more importantly, I want to call to attention, that because of these efforts, so far, we've got some signs of hope. So nearly 75% of all racial and ethnic groups over the age of 65 have been vaccinated here in King County. And nearly 95% of our American Indian, Alaskan Native, and Native Hawaiian Pacific Islanders over 65 have been vaccinated. Next. So I want to leave you with pictures again. And these come from a unique partnership that we have, both in terms of private and public funded sponsors who are working with our community partners on communities of opportunity. And so when we reached out to our community partners and we wanted to demonstrate the strength, but also an acknowledgement of our various cultures in which are beautiful and from which we come from. And these are some of the pictures and slides that have been created, and we certainly have more, but just to leave us with a little bit of hope. And with that, Dr. Ford, I'll turn it back to you so we have a few moments for questions.
Thank you. And I appreciate you really bringing life to these questions by the pictures that you showed. And that helps to anchor our understandings in terms of the local, as well as recognizing the global relationships. And I'm going to ask all three panelists to now come forward. So I want to first thank you for your very thoughtful remarks. And I just want to pose a few questions to you all. But before I do, let me just ask if any of you have questions for the other panelists. And if not, that's fine, but I just wanted to give you space for that. Okay. Well, let me start by just raising this question. Each of you have been working on health equity, certainly before it became, quote unquote, a thing. I wonder if you could say a word or two about your trajectory, especially Lisa and Marguerite. You didn't talk about that part so much. And also about what you make of this particular moment, the shift towards explicitly naming racism and talking about equity and anti-racism for all of you.
I can go. I thought you wanted Lisa and Marguerite to go. For me, the trajectory dates back before I even realized that I was doing health equity work. Before I had the language to call out what I was doing, and I was doing it outside of the workplace. And I think it was fulfilling something that I was missing in the workplace, because I was becoming more disheartened at the point of care by all of the different lists and metrics and things that were being voted on me as a PCP. And I felt I was getting further and further away from my patients. And no matter how good of care, quality care work that I was providing to my patients, I still felt like, something was missing that I couldn't articulate. So coming out of residency training program, I found myself pulling on my strength, my area of strength, which is the faith-based community. My husband's father was a pastor of a megachurch. That's how we ended up here in California. And I knew that that's a trusted community as far as, whoever's in that pulpit, they're going to listen, right? So I leveraged my relationships in the medical community and partnered with, say, Agron Pharmaceuticals, for example, and did 5 years of World AIDS Day programming in South Central LA at my father-in-law's church. So you have over 3,000 people, captive audience that's there. And it was an opportunity to be able to educate and to do testing, within the community. Back then, it was taboo to talk about sex and drugs and, sexuality and all that within the church walls. So it was something that was novel, for back then. Now, not a big deal. Back then, it was more of a struggle. Transitioning from that, I went on to oversee a mentoring organization for women and girls for about 10 years, also in South Central, with a number of hard situations that we had to deal with. And I felt like it was my way of dealing with health issues using mentoring as a tool. So that, and like you mentioned up top, traveling abroad and doing medical missions work in other countries, say in Haiti after the earthquake, to be able to provide medical care to Black and Brown communities that even in crisis situations. These were all the things that pointed me in a direction that I didn't even know that I was headed as a PCP in terms of transitioning my career into public health. And that's what led me to go back to school and even enter at UCLA, was those experiences outside of the exam room, because inside of the exam room, I did not understand why certain populations were still disproportionately represented as far as health disparities. So that's it in a nutshell.
Mm-hmm.
I'm happy to jump in real quick.
Please.
And I so appreciate the story and the personal sharing of tales. I'll just say that as a daughter of immigrants I grew up essentially in a white community where my folks didn't understand the systems, and so where I am is it has to in part be by fate, because the privilege that other children had are not the same that I had, right? And I'll just say that as an Asian American woman, I don't actually remember having a professor. I think I had one Asian American professor and the reality is through my academic career until I got to the School of Public Health at Hopkins, did not have professors of color and of those who would take an interest. And it wasn't until one of Dr. Marsha Lily Blanton, who is an African American, and I know Dr. Kakari Stone knows Marsha as well, who took me under her wing. And then my early part of my journey and my career, I've been so fortunate and worked a lot with the Kellogg Foundation, in part because, again, of African American women leaders who brought me under their wings. And so what I see as part of my journey is to create and support that pipeline of students of color so that they too can be leaders in our communities. I will say, as an Asian American woman, part of what being an Asian American health leader means is to break stereotypes. It means to speak up, it means to lean in, and it is to share those personal experiences and stories and to say that we can, if we can do it, others certainly can as well, and they should.
I just want to add, thank you, Dr. Rowe. I remember our time, we're first circling from the Kellogg Network. I grew up first generation college educated. I'm the granddaughter, la nieta de abuelos de Mexico. I'm from indigenous Mexican roots and English, Irish, and French roots, all farm workers, rural health workers, railroad workers. I think that restorative justice, racial justice, and equity is a core value that I grew up with. Being servant leaders and thinking about the collective is the strength and epistemic advantage that I bring to the table as a Chicana and a queer out lesbian woman who has been in the academy. I grew up with two brothers who are gay, a sister who's lesbian, and it's critical, especially with Latino communities, that we not be homophobic. So I think it's in our DNA as women of color, as leaders of color, to achieve social justice. We are not pivoting our work, we're deepening our work right now. And I think now is the moment. We've been trained for this moment for years. And this is the moment, and I want to just add, I love that you have and value that you brought together intersectional perspectives. We have to move beyond our silos to achieve racial and social justice, to move beyond just taking care of our own. We don't need to fall into cave into that sense of competition, that sense of these type of lives matter. Yes, Black lives matter. We have to recognize the history. We have distinct histories, but shared destinies. Asian lives matter. Indigenous, Latino rights, queer, disability. So we have to always honor the context of which people are talking. But I just want to say, most importantly, it's in our DNA to come together and to not to cave what we call to the crabs in the bucket. Do not need to pull each other down. And I'm speaking to a lot of communities of color right now. We are not in it to compete. We're in it to achieve this together. So thank you.
Let me just ask one last question before I open it up for Q&A, and that is, if you could pose one question or make one recommendation to policymakers, what would you want them to respond to?
Well,
in this moment? Mm-hmm.
I'll start. I think that at the local policy makers, in terms of city government and county government, there's like 1 degree of separation. So we have the opportunity to have a personal connection and to deepen those communications and talking points. At the state, federal, and tribal level, the same thing. We need to deepen those connections. And I think the message as we think about public health and this Public Health Week in this moment is that we have to tackle both structural inequalities and racism and inequalities in the healthcare system. It's not either or. And what I've seen working at the federal government for Senator Kennedy as a fellow, at the state policy level, is that it's separated. People who work on immigration issues don't think about public health. People who work on land and environmental issues don't think about public health. People who work on the healthcare system issues aren't thinking about structural determinants. So I think we need to start unifying these two camps and bring them together.
I'll just say that I think that it's about respect and self-determination, and that really what we need to do is share power with our communities and let communities lead the way as they in general know what's best for them and how to create lasting equitable change. And so what's most important is that we shift power at this point and know that it is for our common good.
I would say I would encourage my policymakers to look for disparities at every opportunity and to look for inequities so that they can speak to that and move in action as opposed to continuing with the status quo the way it has been and with a blind eye to communities that are continuously being slaughtered. You know, I feel like as a healthcare physician, I'm always looking at ways that, in particular, the insurance industry, your payers can be held more accountable. I think the government and payers in particular, if they were incentivized to incentivize other people in the area of looking for disparities and addressing them. So when you talk about quality measures, you should also include in there health disparities and reduction of those health disparities. So for me, when I think about policy makers, you know, it's so complex. It's beyond what I do as a healer, really. But I would speak to it from the perspective of, I think if we look for the disparities, if we intentionally embed it in everything that we do in writing policy, that will move the needle towards greater equity.
So that really dovetails nicely with the first question we received from the audience, which is, what has been the impact of capitalism in healthcare in regards to racism and social justice social issues, remembering the dominant transitions in the 1980s to 2020 of healthcare systems and delivery driven by consolidation, network dominance, and transitions from nonprofit to for-profit care. So we actually received several questions along those lines. I wonder if you all could speak to those.
It's about 3 or 4 of those questions that we saw in advance. I would say when a person thinks about why there was so much consolidation of hospitals, it was out of necessity. A standalone hospital couldn't compete against the behemoths that were, as other groups came together. So it was out of necessity to remain viable, oftentimes, that these institutions had to do that. When you see acquisition of non-for-profits by for-profit agencies, it changes the lens and the orientation from the community benefit oftentimes. And so you find yourself being lost as far as the community and the connection that community may have had to the not-for-profit business prior to the acquisition. However, there are some limitations in nonprofits oftentimes in terms of data gathering and having the infrastructure and the resources available to them to be able to gather the information that would empower decision makers to be able to allocate more resources and monies to those communities. And so when you look at for-profit agencies, they have the infrastructure, the data analytics and all that to be able to do that for some of these communities. So that's the argument for it. But in my heart, I know that there's a loss of the community orientation when you go in that direction. But I understand, but there is something that is lost when that happens. So that's where capitalism comes in terms of diminishing the social justice message and the health equity messages that are out there when you see that happen. Yeah.
I just want to add that thank you for those questions, and we could have a whole nother forum just on those, so I appreciate those. Capitalism and racism are mutually harmful and reinforcing systems that can create poor health outcomes. And I want to highlight a health system that actually mitigates that, and that's the community health centers. That's the federally qualified health centers. Was born out of the war on poverty and the civil rights movement and the Economic Opportunity Act of the 60s. They currently serve, I think we're up to almost 28 million, maybe 30 million, most underserved, under-resourced communities. They do not turn anybody away due to race, language, and citizenship status, or any other status that a person has. And I think we need to learn from community health centers, because it's the only legislation in the healthcare system that requires civic participation, civic engagement of the patients and the communities. 51%. The hospitals have tried to mimic that so they could get the monies. Now, this is important because it's a form of equity in healthcare legislation. We can never lose it. And we've been fighting in reauthorizations that 51% requirement for more than, I think we're on like 45, 50 years now. So I just want to highlight that's an example that mitigates capitalism and racism.
Can I add just one thing to piggyback on what you said, Lisa? I would say I would encourage payers or for us to have payers to risk adjust clinical performance scores for socioeconomic level of our patients. And that would level the playing field in terms of pay for performance. I bring that up because we are always behind the 8 ball, and there's so many other dynamics that contributes to the health disparity that's beyond the control of the primary care physician that's doing their best, that's doing everything. And they don't take into, those scores don't take into consideration the population itself. So that's one thing that I would add as far as the economic side of it.
Well, I'll just add to that, that we also don't have performance measures that we tie financial incentives to around equity, right? So, I mean, that's what we do. We drive towards measures and we use those financial incentives. So that's the next body of work that we need to do in those healthcare systems.
And that can happen if it's more transparent as far as the data. If you make, because health plans have the infrastructure, they have the data analytics available to them, they have the resources, they have the lives attached to it. So if they were to attach to performance measures and incentivize for, you would see more clinicians and administrators in doing initiatives that are driven to meet, closing the gap on health disparities. If you make the data more transparent by stratifying them by race, by ethnicity, and by socioeconomic status. You do that and you make that public knowledge, you'll see some needles move, I believe, in health equity.
This next question comes to us from Samuel Gonzalez. It's amazing to see a panel of diverse women. Conversations regarding systemic racism, hate crimes, and other health inequities and how they affect the health of underserved, non-white communities need to continue and must be had more often. How do we encourage our alma maters to continue these conversations? How do we also encourage them to hire more diverse faculty and guest speakers? So I did just want to underscore, for those who may not have noticed, that this is really a rare moment to see the panel that we're seeing here. And each of you has served on a faculty. So could you talk about, could you respond to this question?
Ooh. Margarita or Lisa, you want to go first? I don't want to get in trouble.
I'm going to talk about schools because it's Public Health Week. I'll talk about schools of public health and academic teaching institutions. People of color are missing in the upper echelons of leadership and academic research, academic teaching, and leadership at the institutional level. So we need to move leadership, and there needs to be more. We can't just recruit, we have to retain and sustain people. Once people, especially women of color, meet a certain level, we leave. Diversity is not a training event. It's a commitment and a process. There's a lot of people pivoting right now to say, let's do DE&I training. Let's do this. Everybody's rushing in the academy to do this, but there has to be institutional resources and systemic change in mind with outcomes and metrics. And we can say the same, performance and incentives to do so. And I do believe that all performance reviews for faculty and leadership should be considered a DE&I. What are you doing to contribute to help alleviate the minority tax for faculty of color in institutions? I think these are critical, and there should also be from regions. Particularly, I'm at a Hispanic and minority serving institution. We need our regions and our leadership to hold people's feet to the fire. You talked about micro and macroaggression, Dr. Lyons-Jones. These are rampant right now, particularly amongst our students, and the faculty are feeling it. So I think we need some mechanisms at the structural level to be able to tackle this publicly.
Mm-hmm. Mm-hmm. I see in the chat box they're saying there's a time limit, maybe 1 minute. So that was so eloquently stated. I'm going to leave it there, Lisa.
Yeah, I was going to say Dr. Kakari Stone said it well.
Yeah.
For Dr. Rowe, we have a question. What are some specific best practices that have aided equity in vaccine distribution in your experience?
Really by having, making sure that our pandemic and racism community advisory group has been positioned so that they have a direct input into what we do, how they review all of the proposals for what gets done. They help us understand where we need to invest in. And we have this equity response team, not just for many reasons, for I think racial equity certainly, and and equity for different populations, but also to look at the ethical considerations of how we develop our systems. When you put those pieces in place and you are consistent and you are insistent on making sure that they are part of the decision-making body, you get to see real change happen.
I think I'm going to try to squeeze in just one more question. And it is, in your perspective, for all of you, what should a project of equity-focused quality metrics look like? How can we build this focus into quality without creating too much individualization or a deficits mindset?
You know, that is just such a big question. And I'll just say that you can't just set performance metrics without the intent, and this is where government comes into place, right, of aligning incentives with those metrics, right, and then following through and having part of, again, that panel that decides. So when I sit on our governor's performance measures task force that has the payers and the providers at that table, I can tell you that the community perspective and the equity perspective is not first and forefront in those conversations. And they're scared, right? Rightly so. But that depends on where, you know, our public dollars should go. And we hope that then our private systems follow along.
And taxpayers should make public institutions, accountable for doing that. I think we lose that opportunity, but the taxpayers have a voice in it. And so if the collective consciousness of a nation is awakened, that like we're seeing right now, you look at New York Times bestseller list, look at how many books about race and anti-racism and, you know, Michelle Obama's book. I mean, all of these books are bestsellers now. And so that's letting us know that people are seeking, they're trying to do the work, you know, on an individual level, and that as a nation, the conversations are, you know, everywhere. So I agree with Lisa when she said it earlier, that this is the time, you know, to do it, to be able to make the things happen that Marguerite mentioned.
I'll just say that, you know, if you look at our nation's demographics, right, and we look at the demographics of children, over 50% of children are children of color already. So we're as a nation, we will be a nation of brown people, and so this is the work that we do isn't just for us, right? It is in fact for our children that are our children now, leaving a legacy, hopefully a very positive legacy for them. We have a lot to fix, but for generations to come. And that's what this work is about.
And it's not a zero-sum game. You know, what benefits, if you go and with equity, you're talking about allocating resources, not equally, but according to need. And in doing that, there are some groups that may view it as, you know, a competition, like this group is getting something that I'm not getting, and this is to the demise of this group, or this will hurt me if you get that. I think if the conversation is elevated the way that it is, and it keeps elevating so that we all see that this is our problem that's going on in the nation, and that we lose out in terms of being innovative and tapping into untapped communities as a result of looking at it in that zero-sum mindset, we're going to continue to have the downward trajectory that we're having as a nation and as a superpower on the world stage. So it's a big, you know, big picture view of it, to go beyond the me syndrome and to see we.
And then Lisa.
Oh, I was reading the question. I don't know if they're referring to the healthcare system, but I do want to talk about equity metrics as we think about public health practice and policy. And we have to move beyond this equity as a core value. Yes, it's a core value in principle, but what does it look like in practice? What does it look like in policy? So the injustice we do is we allow the thought industry to lead with tools, and I'm talking about myself being in the academy We have to go back to what Dr. Rowe was saying. Allow the communities to lead, to define what equity is. I did an assessment of how, at the National Collaboratives of Health Equity, how does communities define equity? I did that too locally in New Mexico. They're defining it completely different. Therefore, the definition and the framing and how they experience it, embody it every day, should actually drive the metrics and solutions. To what level do we have metrics around inclusion and parity and processes that we have in the community and community health? To what way do we actually mitigate and allow communities to drive the solutions, for example, in vaccine equity? To what ways do we bring in the structural and social determinants of health and everyday decision-making and public health practice and governance and policy? In what way do we bring and have outcomes around distributive justice and redistributive justice in mind when we have community health type of interventions? And in what way do we debunk political agendas and we actually become brave and we become courageous and we actually challenge people who are in charge? Because we're starting to see a whole slew of professionalization in equity. I'm an equity expert. What does this mean? We need to bridge people from the past who are part of the American Indian movement, the Brown Berets, the Civil Rights Movement, women's movement, disability rights movement, LGBTQ, with the current generations. We have to learn from each other and not have ahistorical perspectives. And we have to also challenge partners who say they're thought leaders. We are thought partners in this together, and communities are our strongest thought partners. So I just want to say equity, the biggest metric is to not have a top down, is to really think about bottom up and how we think about moving across silos.
Yeah.
Thank you so much to our distinguished and extraordinary panelists, and thank you for spending your evening with us. I want to thank you not only for your time here, but for the work you have been doing for a very long time.
Thank you.
That concludes this portion of the evening.
Hi, everybody. I'm Avram Kaplan, and I'm going to say a few words in closing. And first of all, I want to say that I'm a member of the Paul Torrens Forum Advisory Council. Very pleased to do that. I'm on faculty of the UCLA EMPH program as well. So this concludes our webinar portion. And I want to thank you, Dr. Ford, and all of our presenters for taking the time to join this evening. I hope I am being heard.
You are, Jack. You are.
Okay, thanks. So we're grateful that we are able to have you share our perspective and discuss the important issue. And thanks also to our audience for joining us. I want you all to know that a recording of this webinar is available on the FSPH website. This is the last health forum of the academic year, and we want to thank everybody who joined us for this and for previous sessions. Before we conclude, I want to mention that we have a Health Policy and Management Alumni Association Leaders of Today virtual award celebration on May 20th, as you see on your screen. I encourage you all to purchase a ticket to support this event. Purchasing a ticket helps to support fellowships for HPM students and professional development events for student and alumni. And quite frankly, it's a great time to network as well. With the session now concluded, it's time to begin the optional networking portion of the evening. I'm going to be one of the hosts of those sessions. If you were registered for this, please log off this meeting and log on to the Zoom link that was provided you to access this event. Once you log on, you'll be assigned to a breakout room where you'll be able to chat and network with the others in your room. And so please allow a few minutes for the breakout rooms to be set up So I want to thank you all and have a good evening, and we'll see you in the networking event. Appreciate it.